All right, so I'm here with Joey. So you're a certified physical therapist. Um, and I wanted to discuss with you this really interesting study that came out of Tulane University just recently. Sherman and colleagues, they looked at a group of patients retrospectively to compare tendon and ligament injury between patients who are on TRT and patients who are not on TRT. And what they found was very interesting because it seems that patients who are on TRT, and I've seen a fair amount of patients and sometimes run into cases where they have ligament or tendon injuries. And so they're looking into this study where they looked at 112,200 patients over a span of several years retrospectively, and they found out that many of these patients on TRT tend to have an increased risk of tendon and ligament injury. So what is your experience with patients who are on TRT or have used anabolics and ligament and tendon tears?
Okay. So I haven't had a ton of people who have actually been on like hormone replacement therapy, anabolics, TRT, but I have treated tons and tons of tendon cases. You know, your classic three are going to be rotator cuff tendinopathy,
Right.
patellar tendinopathy, Achilles tendinopathy. And after doing a little bit of a lit review into the TRT world, it seems like the evidence that's out there now is that the muscles are going through more quick adaptations and changes from like a hypertrophy and force production standpoint faster than the tendon. So basically that's adapting at a faster rate than the tendon can keep up. So it creates this basically a mismatch, right? Your muscles adapting so quick, your tendon can't really keep up. Your training loads are probably increasing, your weights are increasing probably in the gym, but the tendon hasn't had time to basically adapt to that stimulus or adapt to that stress, which makes sense why some of these tendons can get irritated or create micro damage over the course of time, which could eventually lead to that tendon rupture, which would obviously be worst case scenario. And it seems like with this potential use of TRT, it seems like the evidence isn't super conclusive, but maybe predict or a delay of collagen turnover, a delay in tendon remodeling, which can lead to basically further of a mismatch of that muscle and tendon adaptation change.
Right. Yeah, we're definitely going to look into the different mechanisms that might lead to higher risk of tendon and ligament injury, because obviously there seems to be some association, but there's not necessarily causation, right? And besides, this is a retrospective study. It's a very good study. It's large. It's powered enough. But at the same time, being retrospective is not that higher up in the evidence-based world. And again, it doesn't really establish causation, but we're going to look into some of the different mechanisms, right? So just to highlight some of the most important aspects of the results and the conclusion of the study that they looked into. So within 1 to 2 years, compared with control, so people who are not on TRT, patients who are on TRT demonstrated significantly higher rates of rotator cuff repair. It's a very common injury that you see. Distal biceps tendon repair, that is also very common. And I actually had a few cases of patients on TRT who've had issues with biceps, and patellar tendon repair, right? So we're gonna look into some of these mechanisms, right? All right, so talking about like some of the mechanisms that might lead to an increased risk of tendon and ligament injury and subsequent repair, right, or orthopedic visits or physical therapy visits, is the biology behind it, right? So animal studies have demonstrated that testosterone increases tendon stiffness basically by increasing collagen turnover, right? So what that means is that it will downregulate relaxin receptors on tendons. And relaxin seems to be a very important protein to, obviously, what it means is like helps it relax and helps it be more, let's say, what would be the word? More
Compliant?
Yeah, more compliant, right? And then, relaxing basically increases the laxity of the tendons, right, and the soft tissue. And it seems like testosterone downregulates this, at least, biologically in animal studies. I don't know if this happens exactly in humans, but this seems to be one of the possible explanations. Besides, obviously, patients overdoing their muscles, right? And then also, what another important aspect is that testosterone or anabolics seem to also decrease and downregulate what's called matrix metalloproteinases, right? And this is really important protein in the tendons that limits its regeneration, right? So we need these metalloproteinases for regeneration of the tendon, right? So in your experience with a patient, whether they are on TRT or not, what is your experience with stiff tendons or ligaments, right? Like what could happen to these patients potentially?
From like an exercise perspective, they typically have some pretty general complaints. Like obviously it's going to be direct focal pain like on the tendon, specifically like if we're talking patellar tendon.
Right. Let's talk about like patella.
Yeah.
Which is one
So
of the
if,
most common
if
ones.
we're talking patellar tendon, they're going to have literally direct pain like right at that inferior pole of the patella. And depending on the severity, it could be irritated from a variety of things. The biggest one is mainly like deceleration things like jumping, landing, where there's a high impulse, basically a large amount of force happening over a very short period of time.
High impact.
High impact, basically. So the tendon doesn't have the basically bandwidth to handle that impulse of such a high force over such a small period of time. That's more of like your late stage. Like we want to obviously get them close to being able to handle all the repetitive stretch shortening cycle stuff. And then if it's, really, really bad, everything's going to really bug it. Any sort of like isometric contraction at a higher intensity, say like above 70% of someone's 1 rep max, that's usually not handled very well. Heavy slow resistance usually isn't handled very well either. So it depends on the irritability. If it's a very moderate tendinopathy, usually they do well with the isometrics and heavy slow resistance, but not very well with the repetitive impact loading. Mm-hmm. If it's really bad, all three are going to be very, very irritated. So knowing basically what type of contraction or the magnitude of loading or the rate of loading is very helpful for me because it gives me an idea of kind of where are they on that loading or irritability spectrum. And then we can basically formulate a program to where maybe we're holding off on some of the stretch shortening stuff, emphasizing just the heavy slow resistance and isometrics, and then layering that in once the tendon calms down a little bit. It's very similar to, I don't know if you're familiar with Jill Cook. She's a big tendon researcher out in Australia, but it's basically trying to keep as many contraction types in somebody's program as much as possible. So in like an irritable case, you have like your isometrics as your entry point, and then once it's appropriate to add isotonics, those become like the main emphasis, whereas isometrics become like more of your home program or supplement. Then once it's appropriate, we add the stretch shortening cycle stuff or repetitive impact. Then the heavy slow resistance isometrics become more of your supplements accessory. So now you have like a whole big picture, well-rounded program attacking a variety of contraction types.
Right. And if you had, let's say, a patient who has this issue of, let's say, stiff ligaments or at risk of tendon injury, I guess it just, in my mind, I'm not a physical therapy expert, but how do you approach to try to protect, these patients the most? Do you have to build more muscle around these tendons or these ligaments, or how do you work around that?
Yeah, so I think the concept of like exposing versus protecting is big here. Like obviously we want to expose the tendon to get adaptation, but we also want to protect it to where if we overexpose it, then we're potentially doing more harm than good. So it's kind of finding that, I guess you can call it Goldilocks sweet spot. Right? Yeah. So there's plenty of tendon research to show that pushing through pain is acceptable and honestly encouraged in many scenarios. Like I've seen several patellar tendon studies that have like 4 out of 10, even some as high as 5 out of 10 pain as like an acceptable range. Wow. So I'll usually, if we're doing like isometrics, isotonics, hey, we're going to push as hard as we can up to like a 3 or 4 out of 10, and that's going to be our cap. If it's above that, we've probably annoyed it a little bit too much. We have to back off, whether we change the weight, change the range of motion, change the tempo to keep us in that 0 to 3/4 zone. Yeah. That's kind of where we want to live. So that way we can continue to make progress, but not have to wait until pain's at 0, because it's unlikely, at least initially, to do everything at 0. It's not going to be realistic.
Right. Then there's not going to be any progress in the patient's.
So just getting them to understand that it's okay to push through some pain as long as we're staying within those confines that we set, basically.
And I'd say that it's also important to mention that that's under professional supervision and a professional program, right? And that's where the second possible cause of higher tendon and ligament injury on TRT patients comes along, that these patients tend to they just overwork it, right? Because they feel stronger, and they do become stronger. I mean, one of the main things that I look for in my patients on TRT is like, hey, how are you feeling on the gym? Are you working out stronger? Do you feel that you recover faster? Are you gaining muscle mass? And most of the time when they're on TRT, the answer is going to be yes. And they're just going to sometimes overwork it, right? So I think like that's the other part of it, where they're not really following a supervised program. They're just doing it on themselves, and that can lead to tendon injuries.
Yeah, and that brings up an important point of prepared versus ready. A lot of times people like feel really good and think it's okay to really push the needle, but we haven't really built enough of that chronic workload to where it's able to actually handle that stimulus. It can probably handle it once, but can it handle it 3, 4, 5, 6, several dozen times? Probably not. So that's kind of where people fall into that trap of, okay, I'm feeling good, let's really get after it.
Yeah.
And potentially setting themselves up for a setback because it was scaled a little bit too quickly.
Right. That's very interesting.
So I want to hit on something that I feel like is still a pretty big misconception, especially when somebody's coming in with tendon pain. Even with really most injuries in general, I feel like the default advice is typically, take it easy, rest, don't do anything, ease back in when it feels better. NSAIDs, yeah, exactly. Heat, ice, the same rice principle. But honestly, the best thing you can possibly do when you have an irritable tendon is load it and not rest it, because tendons basically love load and they need load to adapt and remodel. That doesn't mean, we load it and blow past an insane amount of pain. It means we obviously have to be, pretty cognizant of how we're structuring a program, what exercise interventions we're doing, what intensity we're doing it, but it needs to be loaded at a comfortable, basically zone of pain to be able to give it enough of a stimulus to adapt and remodel. Whereas if it's resting, it's not getting any of that stimulus.
You need to keep that tendon going. Like you need to keep the tendon under stress.
Correct. So
maybe
at least
less.
several times a week of, some even have, I think, can't remember, it's the Alfredson protocol or another one of Joe Cook's papers, but like pretty frequent bouts of loading, I even think throughout the day, has been shown to be helpful for that, versus just not doing anything.
Like if I had a bicep tendon, what you call like irritable, ligament, right? So it's hurting. I worked it out too hard. Let's say I go to the gym, but I'm not gonna work it as hard as I would, but I still want to put some load on it. I would still want to work out my biceps to keep it going, right?
First, I guess, point of attack, if it's really irritable, a simple like isometric, so like just pulling up into like a table or a bench where you can work at a pretty high intensity but don't have to worry about any irritable ranges of motion. I feel like a lot of times like that end range eccentric is what gets them a lot, especially if it's irritable. So sticking to that mid-range or even shortened range can be a little bit helpful to still work at a high intent but not get to those provocative positions. And then some other like simple weight room variables that we can adjust. First one would be we can implement a tempo. So if weight is a limiting factor and say they're doing, I'm just making this up, 30-pound curls with like a 101 tempo and it's irritating, if we drop to a 15 and do like a 3 up, 3 down, they're working at such a high intent or like internal rating of perceived exertion, but the external load is low. So that would be one of my go-tos to where we're still working at a pretty high intent, like mentally or physically, but the loads are low. So that would be an easy swap to where we're not using as much external load, which can honestly feel a little bit better, but they're still working at a high intensity. So those would be like two go-tos.
Very interesting, man. Right, so I'm gonna go a little bit off the study and I just remembered this about some patients that I have. A lot of my patients sometimes ask about nandrolone, which is it is an anabolic. Out there, some people might know it as DECA. That is sort of like the street name. But as a matter of fact, you can get prescribed nandrolone as an enanthate form, so it's a long-acting. So you inject nandrolone at a prescribed physiological dose, and it's supposed to help with tendons. It's supposed to help with ligaments. Let's say that if a patient has some, I don't know, like a shoulder pain, they're doing TRT, they might have done other anabolics. I guess the common knowledge in this gym world and anabolic world is, hey, add DECA to your stack. And because the thought process is that it helps lubricate the joints. But what I was reading, and I was discussing this with some other TRT experts, is that it doesn't really help regenerate the joint. It helps like lubrication. So it might just mask the pain enough, and then they're gonna push it even more and lead to even more tendon injury. I don't know if you've ever had or heard about it, or if not, is there some other way or some other medication or physical therapy that you use that helps like lubricate? And what does it mean when you lubricate like the joints?
I mean, basically every joint is going to have synovial fluid surrounding it. That's basically like your body's, I guess, own lubrication, right? The older we get, the more our joints change. That might change the ability to adequately, quote unquote, lubricate the joint, especially in like your arthritic conditions, where we're seeing like, true structural change. But I'm still a big fan of always supplementing your strength and conditioning work with like actual mobility work, because we obviously want to try to maintain as much functional range of motion as possible. And you get a lot of your meatheads that do the same routine over and over again, and they come in, you get them on the table, and they're like stiff as a brick. So like they're not able really to get into positions that their arm probably hasn't been in so long, like
years.
You get somebody who's wide lats,
huge,
walking in like a brick, they can't rotate. You get them on the table, they have this much shoulder flexion. So like this part and higher has never seen any love in that joint at all. So like that's my big thing on like trying to maintain as much functional range of motion as possible. So that way basically you're naturally just lubricating it with your mobility and with your training.
Mobility. Yeah, I'd say like that's more important than adding more anabolics or even like supplementing with, I don't know, like in your experience, is there any role for, I don't know, supplementing with collagen, or is there any over-the-counter supplement that you would say, okay, like this is really good for lubricating the joints?
Yeah, that's definitely a little bit out of scope in terms of like, obviously I'm not a registered dietitian or anything, but I have seen some studies. It might be, I can't remember if it's like acute ACL surgery or like a very acute tendinopathy, of them supplementing with pretty heavy doses of collagen like pretty frequently. I don't remember the exact dose, so don't quote me on anything, but utilizing that like early on to help at least with some of the remodeling, it seems like has been shown to potentially help. I don't think anything's like confirmed via like any of the literature, but I've seen that in some studies where that's been like used as like an immediate supplement.
Yeah, that's a lot. That's a very similar answer that I would give to some of my patients asking for that. I'd be like, listen, there's no hard data on it, but if you want to try it, some of it seems to indicate that it might help, right?
Yeah. All right. So question for you, and let's use like the patellar tendinopathy case or the distal biceps tendinopathy as a case. Let's say someone is on these anabolics. How does the stack they're on, the dose of those, and basically the interaction of all those impact the timeline of healing, or that area that is under stress or increased pain?
That's a very hard question, Joey, because there's no data to let us guide a patient through a tendon injury, and what do we do with their doses, right? So I mean, I'm used to and I'm very experienced in adjusting the patient's dosages, right, of TRT. I have patients who are sometimes on anabolics, and they might ask me, I'm adding this compound, I'm putting on this other one, and I can guide them and tell them, listen, you need to be careful, we can watch this blood parameters. But I've never had the opportunity, or at least a case where I mean, I've seen a lot of patients on TRT who get tendon injuries, but I've never approached it. And this paper makes me think about like maybe I should have a different approach, but I've never approached it in a sense of, okay, you know what, we need to adjust your testosterone dose, right? And it sort of like makes sense maybe to adjust it if it's a really bad injury, one that the patient is going to be on some pain medications or NSAIDs or will need rehab or physical therapy. I'd say that if I ever encountered a patient who experiences such a bad tendon injury, like a tear, that has to go under anesthesia to an orthopedic surgeon, I think at that point I would tell them let's back off a little bit on the TRT dose, mainly to try to protect them from overdoing it, and also keeping in mind this physiologic mechanism of the relaxing and the metalloproteinases, right? If this mechanism is true, then I think there is some truth in trying to reduce the dose of the TRT, not cutting it off, right? That's something that I would never do. I mean, I don't think there's any single case where I would be like, listen, we just have to stop it cold turkey. That would be very dangerous. I do want to put that out. But maybe reducing it to first maybe address this physiologic response of the relaxin, and to help him just feel a little bit more physiological and not overdo it. So I think that's what I would do now if I encounter a serious tendon injury. That when I say serious is one that leads to surgical repair. Yeah, that's what I would do.
Okay.
All right, so I mean, this study I think is really good, and this is why I'm bringing it up, and I brought it up before, and I think it's very interesting, especially because now there's so many people going on TRT, and it's gonna be more and more, and I think you're gonna see it too more. So I think my take-home message would be that true optimization is an ecosystem, right? So obviously you have the hormones, you have your lipids, you have your hemoglobin, hematocrit, all of that stuff, like risk mitigation that I always talk about. But now we should also include this, right? Now we should also include tendon health, right? And musculoskeletal injuries. And that's my take-home message.
I'll go with my take-home is that tendon loading or tendon healing takes time. It's not, a 1, 2, 3 week thing. Like, we have plenty of data to show like true tendon changes can take months, several months, like 3+ months, 6+ months in some cases. So even though you might be feeling good and feeling ready to push it, especially, given the positive change that we can see from TRT, especially from like a muscle force or force production perspective, just because you're starting to move more weight doesn't necessarily mean that's the indication to keep jumping the gun and progress too quickly, because of that tendon mismatch of it taking a lot more time to adapt and heal than the changes that we see in a muscle. So that would be like my main one. And then the last one is don't rest a tendon. That's probably the worst thing you can do. Load it up. Obviously, you need a structured, smart, safe program, but loading it over the course of time is what actually is needed to give it enough of a stimulus to mechanically change and adapt.
That is new to me because, if I wouldn't have had this conversation and if I suffered a tendon injury, I would be like, I'm not gonna work out that tendon for a month.
Because then what's gonna happen? You've gone from no loading to trying to get back into it in the gym again.
Yeah.
And then it's basically that mismatch all over
Makes
again.
sense.
But you're starting from a more deconditioned state.
Makes sense.
Compared to when you had it initially.
Yeah, you just don't think about it, right? I don't think anyone thinks about that. Like, I mean, I haven't heard about it, but it makes so much sense. Let me ask you something, Joey. When you have a patient, a client on the table, and you're, working with them, physical therapy, whatever, do you ask them if they are on TRT or they've taken anabolics?
That's actually a good question. Probably something now, given the rise of this, should probably be included in some sort of intake. I asked like current medications, but
a lot of people hide it.
Yeah, I mean, I could have a separate section like under medications, like any sort of TRT, hormone replacement. I don't currently have that now, and even under like the regular medications intake of the form, nobody has written any sort of anabolic or TRT that they're on. But that's actually a good point and something to obviously consider, especially if you're dealing with somebody who has a large history in the gym, wants to get back to something gym or sport related. Like that's obviously helpful information to know.
When you see a patient, I mean, like when you see someone who is on something, you kind of know.
Yeah.
Like, have you had patients like that you suspect that they are using anabolics or TRT? They look the part, and you ask them, "Are you on any medication?" To say no.
In my short experience being up in Jersey, definitely I haven't yet. But I used to work at IMG Academy in Florida, so I was only seeing like 12 to 20-year-old kids.
Okay.
So like
pretty young.
Those kids like were not on that stuff, at least to our knowledge.
Okay.
So I never really ran into that scenario, and I haven't run into it here yet. I mean, given that it's continuing to get more popular, it's inevitable that I'm going to run into it at some point.
I think it is.
But I haven't yet.
Yeah. Because in my experience, at least, what I always preach is that, when I'm encountering a new patient who comes to me looking for TRT, and sometimes they look the part where they've already used something, I just straight up ask them, what are you at? What are you stacking, right? And like if I ask them like that way, like very directly, because it's different if you ask them like, are you on any medication? You give them the option of saying no.
Right, because they don't necessarily view that as a
Right.
medication.
But if you ask them, what anabolics have you ran? Just directly, I know it sounds like crazy that you just, to a random person, you ask them like, what anabolics have you used? If you ask them that way, like really straight, they're gonna be more straightforward with you and gonna be like, oh yeah, I've used Anavar, right? I've used Nandrolone, I've used Deca, I've used TRT, like 500 milligrams weekly. Versus if you ask them in a more defensive way, like, oh, have you used medications before? You give them the option of saying no, right? So that is sort of like what I do in terms of when I'm asking them what are they using, just like face to face, same level, what are you stacking, and they're gonna be a little bit more straightforward.
That's a good point. So definitely something to consider for the intake form.
Yeah.
And asking them obviously verbally in clinic.
Yeah. Very good, man. Thank you so much.
This is awesome.